Good morning. Today we're going to discuss the chapters of pulmonary assessment. So first of all, we're going to talk about the anatomy and physiology of the lung. So basically, remember that we have the sternum, and at the level of the second intercostal space or the second rib, you have what's called the sternal angle or the angle of Lewis. So basically, by palpating externally, you will be able to feel or palpate this fine line, which marks the second intercostal space, which at the same time is where the bronchs starts dividing into right and left. So basically the main bronch. Then you have the cipher process and the body of the sternum. In addition to that, you will be able to count down the ribs anteriorly. I want you to notice that above the first rib, you have at least 1/3 of lung, which is called the apex of the lung. So basically, from the outside, when you are assessing a patient, you could be locate anatomically some structures that are present internally in the lung. As previously stated, if you're able to palpate the clavicle, you know that 1/3 above the clavicle and 1/3 above the first intercostal space, which is right below the clavicle, you have the apex of the lung. So any injury that the patient will come in with or located above the clavicle, you have the risk for puncturing the apex of the lung. So basically, again, try to locate and describe the chest wall. Remember that the chest wall is the physical structure of the lung. We not only breathe through the pons and medulla located at the level of the brain, which basically sends the signal for the lungs to expand, mediated of course by the level of CO2 present. But in addition to that, we also breathe with the participation of the intercostal muscles, diaphragm, and the chest wall. So any deformity that the patients might have can compromise tidal volume and therefore respiratory function. As I previously stated, at the level of the second intercostal space, you have the sternal angle of Lewis, which basically tries to give you an idea where tracheal bifurcation takes place, and also the bifurcation of the bronchs into right and left. In addition, the sternal angle of Lewis is also the upper border of the atria of the heart, and as I said, is located at the level of the second rib or second intercostal space, and also marks T4, which you would see that is the initiation of or entrance or the root of both oblique and horizontal fissures of the right lung. So again, you have the sternal angle of Lewis, which is no more than the second intercostal space, or at the same time you could say that this little hole that we have here, located, that you were able to also palpate, that basically is the connection of the sternal and the head of the clavicle, is basically located 5 centimeters below. So the angle of Lewis is located 5 centimeters below the suprasternal notch. Again, is located at the second intercostal space or second rib, and also articulates the first 7 ribs with the sternum. So you could see that they all have chondral articulation, and you also have at the level of the 8 to 10 rib, they do have costal cartilage, and the 11 and 12, they're basically floating. Okay, so please don't forget to say, to remember that the second intercostal space is where the angle of Lewis is located. When you go to specialty classes such as the acute care, that's exactly the same level in the second intercostal space where you're going to insert a large bore needle to release pressure when the patients have a tension pneumothorax. And at the level of the fourth intercostal space, where basically it's at the level of T4 in the mid-axillary line or anterior line, is where you will insert a chest tube, again, for tension pneumothorax as well, or large pneumothoraxes. Posteriorly, you're able to count all the spinous processes. The most protuberance that when the patients flex the neck is C7 and T1. Then after that, you're able to say that if you're able to locate the inferior tip of the scapula, that will be the seventh rib, which again, that's basically where the oblique fissure finishes. Starts at the level of the fourth intercostal space and goes down into the seventh rib or seventh intercostal space. And as I said, if the patient tends to flex the neck, you're able to palpate the C7 and T1 protuberance. This is exactly what I was trying to explain before. You have the sternum, and this is basically the body. You have the suprasternal notch. You have the angle of Lewis located at the second intercostal space, and then it goes down all the way to the level of A to 10 rib, the xiphoid process. We can trace imaginary lines anteriorly, posteriorly, and lateral to the patient to be able to have an idea where the anatomic landmarks of the lung inside are located. For example, we can trace the mid-sternal line basically to know exactly where the hilum is located, or the mediastinum. The hilum is no more where all the bronchi are branching out, and the mediastinum is where the main vessels, the aorta, the superior inferior vena cava, etc., are located in the center of the chest. So basically where the main vessels are located. You have the mid-clavicular line, which, for example, at the level of the left side, you're able to locate the point of maximum impulse. But for the lung, basically gives you an idea on chest X-ray wise to be able to anatomically locate lesions that you're able to see on radiography. In addition to that, mid-clavicular line, but at the level of C4, you have the initiation of the horizontal line and also the point of mark of the oblique fissure in the right lung. Then you have the anterior axillary line that again you can insert a chest tube at the level of the fourth intercostal space when the patients have, for example, pleural effusions, and also when the patients have large pneumothoraxes. Okay. Then we have the lateral view. That again, this is exactly the same anterior axillary line as this one. You have the mid-axillary line that you also can locate between these two landmarks, fourth intercostal space, to insert the chest tubes. In addition, you can say, well, this is the fourth intercostal space. At this level, the horizontal fissure of the right lung starts, and at the same time, the oblique fissure will start. The horizontal fissure goes from the fourth intercostal space to the sixth intercostal space, and the oblique fissure comes from the fourth intercostal space all the way down to the seventh to eighth intercostal space. Then you have the posterior axillary line that basically is the anterior line for the posterior view. So posteriorly, you can locate the spine process, which is the vertebral line, and also the mid-scapular line, to be able to mark the level of T4, for example, for certain lesions located at the level of the lung. Then, as I previously stated, you have the clavicle, and you know that 1/3 above the clavicle you have the apex of the lung. So any lesion that you are able to see outside, you can predict that the patients would have a major damage at the level of the apex of the lung. As previously stated, this is the horizontal feature, and this is the oblique feature. Okay, you have the right upper lobe, right middle lobe, and right lower lobe. When the patients are resting comfortably without taking a deep inspiration, the lung basically stays at the level of 7th to 8th intercostal space. When you take a deep breath, it goes down to the 12th intercostal space. The same way will be posteriorly. So remember that the left lung has left upper and left lower. This area right here is where the heart sits in the mediastinum, and if you imaginarily take the heart away or through autopsy, this area of the lung here is called lingula, which some anatomists call them the middle left lung, which is not really present, so it is called the most of the time in books lingula, like lingua or tongue in Latin. Posteriorly, as I said, you also have the right and the left lung. Posteriorly, you will be able to see only the left upper and the left lower. As you can see in the anterior view, the upper lungs are bigger than the middle or lower lungs. Posteriorly, you're able to see that the left lower lung are more visible than the upper, the same way on the right side. Again, you have the initiation of the lower lobes posteriorly at the level of thoracic 3. And as I said, there is a major inspiratory descendant to the level of 10 to 12 intercostal space when the patients take a deep inspiration. As well, laterally, you're able to see the left upper and the left lower, the same 3 views of the right lung. Oblique, again, you start at the level of the 4th intercostal space and it goes all the way down to 7th to 8th intercostal space, and horizontal view meets with the oblique at the level of the 4th intercostal space and goes down into the 6th intercostal space. So at least from the outside, you're able to palpate some landmarks and be able to predict what is happening inside of the patient's thorax. So there are terminologies that I want you to remember. You have the supraclavicular space, which is no more than above the clavicles. There is infraclavicular, which is below the clavicle. Remember that above the clavicle, you have 1/3 of the apex present. Infraclavicular, at the level of the infraclavicular is where the first intercostal space starts. It's basically embedded in the clavicle, so that's a little bit impossible to palpate. The interscapular area, it has to be seen posteriorly, so you have to turn the patient through the posterior view to be able to see the interscapular area. When you auscultate a patient, you never auscultate above the clavicle because otherwise there's no breath sounds present. You will be doing your auscultation between the clavicles. Then you have the infrascapular area that, remember, just palpating the border of the scapula, you're able to determine that you are at the level of 7th intercostal space. The basis of the lung, basically you're not going to be able to palpate the basis of the lung, but you have an idea when the patient is resting and not taking a deep inspiration that you are at the level, or the bases are at the level of no more than 10 intercostal space. And then as I previously stated and explained, the left lung has 2 lobes, left upper and left lower, and the right lung has 3 lobes, which is right upper, right middle, and right lower. And remember that in some books you will be able to see that the left lung has a 3rd lobe, which is not anatomically real, but when you imaginarily take the heart away in autopsy or in an X-ray, that area of the mediastinum is called the lingula. Okay? So then, again, as well, imaginarily, remember that the reason why we make you remember the angle of Lewis, which is located at the 2nd intercostal space, is because you know that anatomically at that level, the trachea starts dividing into right and left, and the bronch also starts dividing into right and left. Okay, so you know already that at that level you have, for example, the carina, where the ET tube has to be located 4 to 5 centimeters above. The pleura, this is again no more than anatomy. The pleura is no more than a serosa that covers the lung from the outside. The pleura, as any serosa, has 2 layers, the parietal pleura and the visceral pleura. The parietal pleura is the one that faces the outside of the lung, and the visceral pleura faces the inside of the lung. They have at least 2 to 3 millimeters of fluid that basically serves as nutrition as well as avoiding friction. In periods of inflammation, when the patients have pleuritis, this fluid comes to the outside, and that provokes a friction and a sound that you will be able to auscultate. In addition to that, remember that at the beginning I mentioned that respiration doesn't take place only at the level of the lungs. You breathe, first of all, mediated by the brain stem, and other structures of the brain, which are the medulla and the pons. That sends a signal to the lungs to be able to have a deep inspiration, and also mediated by carbon dioxide levels present at the level of the interchange of the alveoli. So, but in addition to that, you also breathe by the participation of the intercostal muscles and the diaphragm. So any disease process that affects these muscles that provokes weakness, such as myasthenia gravis, and other autoimmune conditions that debilitate any muscle of your body, skeletal muscles in this case, the patients would have decreased tidal volume and therefore respiratory failure. Okay, so we can see, for example, paralysis of the diaphragm in inspiration many times in patients that have coronary artery bypass graft, since they manipulate the diaphragm so much going into the mediastinum, they can produce a paralysis. Tumors located in the abdomen or in the lung can also paralyze the diaphragm, and patients would have respiratory failure due to that. Okay, so assessment-wise, you can see when the patients are on respiratory distress just by looking at the accessory muscles that participate in respiration. So not only the patients would have retraction of the intercostal muscles, but they also have accessory muscles that participate on respirations when the patients are under distress. And those are the sternocleidomastoid, for example. The patients would have tension at that level, and you can predict that the patient is in respiratory distress. In addition to that, the patient's diaphragm will be very weak, and therefore the patients would have abdominal breathing, and we also call that in clinical practice paradoxical breathing. So normally when you breathe, you take a deep breath and the diaphragm flattens, and that's when the patient's or chest wall expands. When the patients are on respiratory distress, the diaphragm cannot flatten properly, and you would see that the patients breathe mostly through with the abdomen, with abdominal muscles. So we presented last week differential diagnosis for chest pain. Now, how can a patient with any respiratory condition present? What are the most common signs and symptoms? Well, any type of disease process that gives you hypoxemia will give you chest pain as well, because when you lack oxygenation or when the oxygen level decreases, the metabolic pathway goes to anaerobic and releases lactic acid. And lactic acid produces pain anywhere in your body. And in this case will be chest pain, okay? Because the lungs are located inside your thorax. So chest pain, but remember that chest pain with pulmonary conditions is not the pressure like retrosternal. The chest pain that comes from pulmonary condition is pleuritic in nature. It's sharp, it's worse in inspiration and cough. And most likely the patient can point exactly where the pain is located. In addition to that, the patients would have shortness of breath. Now, this shortness of breath most commonly is present due to disease process located inside the parenchyma, even though sometimes it's just a lack of perfusion, such as in pulmonary embolism, and the patients have no disease process inside the lung. Remember that in cardiovascular condition, we mentioned that the shortness of breath of cardiovascular condition most of the time comes due to tissue hyperperfusion. So sometimes the patients with lung process can also have shortness of breath without having any pleural effusion or without having any pneumonia or any mass in the lung. Sometimes the shortness of breath is due to tissue hyperperfusion. In this case will be produced by a pulmonary embolism. In cardiovascular conditions, will be due most of the time for myocardial infarction. Wheezing. The wheezing is no more than a musical expiratory sound that comes from a bronchi that is in bronchoconstriction. So whenever there's a closure of the bronchi, either due to hyperreactive conditions such as asthma, or when the patients have a mucus plug, anything that obstructs the exit of air coming out from the bronchioles produces a musical sound, which is wheezing. And the wheezings for lung conditions are in expiration. When you have wheezings that are in both phases, inspiration and expiration, most of the time is produced by a cardiovascular condition. Cough is very, very important that you ask the patient the quality of the cough. Sometimes you just enter the room and you're able to hear the cough of the patient, if it's dry, if it's congested, if it's wet, but ask the patient if this cough is associated with productive sputum or phlegms. And also, in addition, what is the color of these phlegms? Because if the phlegms are, for example, white, transparent, most likely you will be thinking about viral conditions or congestive heart failure. In difference as if the sputums are yellowish or greenish or rusty color, most likely is produced by infectious processes, bacterial in nature. Hemoptysis is no more than coughing up blood. Coughing up blood could be just a simple break of the capillaries inside the lung and can be produced by an inflammatory process. Inflammatory process such as any type of pleurisy can produce a hemoptysis. Infectious processes such as pneumonia can produce hemoptysis. So don't think that hemoptysis is only associated with patients that have tuberculosis. Patients with any infectious process or inflammatory process can have hemoptysis. Now, sometimes patients have vasculitis, so inflammatory process at the level of the vessels located in the lung. And that could be from patients that have lupus that also affects the lungs, patients that have sarcoidosis that affects the lung, and even tumors that can erode the vasculature of the lung, and the patients can have hemoptysis. And also ask the patient, how can you describe this blood coming out from your cough? Is it saliva or mucus or sputum tinged with streaks of blood? Or is this blood coming up as clots? Or is this blood coming up as if you're cutting yourself, which is bright red color? It is not the same, because having phlegms with strikes of blood is called hemoptytic sputum, and most commonly is associated with inflammations or infections, versus when you have frank red blood coming out in large quantities. Most of the time this is due to patients that have tumors or patients that have cavitary lesions that are eroding on the vessels, such as in tuberculosis. In addition, the quantity. Ask the patient how much. So many patients show me pictures of what they have brought up. Or you can able to see at the bedside how much is it in the bedpan the patient's speeding, or sometimes in a cup, and you're able to see the quantity of that amount. Because again, hemoptytic sputum is not the same as having frank hemoptysis. Now, we will talk about how you treat these conditions one by one. Again, going over chest pain again, when you ask the patient, how does it hurt? Can you please describe to me how is this discomfort felt? Don't put words in the patient's mouth, but if the patient cannot come up with a quality or adjective of this type of chest pain, help them, but give them a variety of adjectives. Is it pressure? Is like a heaviness? Is it sharp? Is it stabbing? And they can select from it, but don't just click or give them only one, because many patients will select exactly that one. And mostly when they are coming to the healthcare facility just because most of the time they don't have a place to live. And those are the patients that come frequently to the hospital without any particular symptom. So when you give any adjective to a pain, they will grab into that quality and just give you whatever. Okay? So ask the patient, where does it hurt exactly? Because as I said, pleuritic chest pains are mostly never retrosternal. They basically are pointing exactly where the pain is located. And when you do a chest x-ray or a CAT scan to be able to compare, it's beautiful to see how the lesion is exactly at the location where the patient is pointing at. Ask the patient the 7 attributes of the symptom. Remember, when did it start? Where is exactly the location? What are the associated symptoms? Can you please tell me if this chest pain from 0 to 10? So that will be quantity. So associated symptoms such as cough, such as shortness of breath, such as if you bring up phlegms, what's the color of those phlegms? If this chest pain is associated with fever and chills, most likely you're thinking that this pleuritic chest pain will be coming from a pneumonic process, okay? Now, in addition, try to do a differential diagnosis of chest pain as we already covered last week. I'm not gonna go into detail, but remember that this chest pain is never pressure-like, it's mostly sharp, it's stabbing, it's worse in inspiration and cough. It will never be reproduced by movement or when you press on the area, which in this case will be musculoskeletal. Okay, so remember that any disease process located in the lung will irritate the pleura, and irritating the pleura will produce pleuritis, and that pleuritis produces a chest pain that again is stabbing, is sharp in nature, and is worse in inspiration and cough. Okay, and try to locate the surrounding structures anatomically from the outside, as I already explained to you. The patient points here, for example, you know that that will be the 5th or 6th intercostal space, so you will be paying your attention on the chest x-ray or on the CAT scan when you do that diagnostic test to the patient, going straight to that area to see if you see any type of lesion. Again, shortness of breath, as I said, is just a sensation. Is basically subjective, so sometimes the patient tells you that they do have shortness of breath and you don't see any sign or distress at all, and you would have to basically do an ABG to see if the patient has any type of hypoxemia, or looking at the monitor if the patient has an auto-sat to be able to see if the patient has any type of hypoxia. Remember that hypoxia and hypoxemia is not the same. Hypoxia would be no more than quality SpO2 in an O2 monitor. Hypoxemia is when you do an ABG and you're able to verify that the oxygen level, the partial pressure of oxygenation, which is PO2, in the ABG is low. Normally it's 80 to 100, so if you have a less than 80, you have hypoxemia. Okay, and if you see less than 90 on an SpO2 on a telemetry monitor or on a portable SpO2, then you would say that the patient has hypoxia, okay? So, ask the patient as well, this shortness of breath, do you have it at rest or do you have it on exertion? Patients with lung processes have shortness of breath at rest all the time. The disease process doesn't change. Of course, if you consume oxygen, it's going to be worse. But for example, a patient with pulmonary fibrosis or any type of chronic condition such as COPD or bronchiectasis, they would have shortness of breath all the time. Okay? Try to be able to differentiate if this is only on exertion or is worse on exertion and is alleviated by rest. Most of the time, you're in the presence of a cardiovascular condition. And again, have you had this difficulty breathing before? Not only in pulmonary, but in any disease process, it's very important that you ask your patient, have you experienced this event in the past? Because these patients would be able to describe to you prior admissions and what has happened, what prior diagnoses have been given, so you will be able to compare and target your diagnostic evaluations based on prior episodes as well. And ask the severity, as I said. Your shortness of breath, is it only a rest? If it's only a rest, imagine this is a severe condition. Or you have to do a strenuous exercise to be able to provoke the shortness of breath. I have shortness of breath if I start now exercising, so that will be a mild condition. So just by the activities that the patient is doing, you will be able to grade the level of shortness of breath that the patients have. Wheezing, as I said, this is mostly repetitive, this is musical, is no more than an obstruction. So there's two types of conditions that you would understand when I explain pulmonary function test in health assessment, that one is obstructive and another one is restrictive. Obstructive pulmonary conditions, the patients do have a normal inspiratory process, but at the time of expiration, there is some obstruction to the pathway of air coming from the alveoli to the bronchioles, to the bronch, and to the outside, the trachea, to the environment. So either a mucus plug or a hyperreactive condition that produces bronchospasm will produce the wheeze. Okay? And remember that wheezes, they have different levels depending on the level of bronchospasm. Sometimes you only auscultate the wheezes with the stethoscope, and sometimes when the wheeze or the bronchospasm is so severe, you either have severe wheezes that you can hear from just talking to the patient, or a silent chest, and that's an homonymous sign, homonymous sign of respiratory failure. When you hear nothing, no gas exchange, no inspiration or expiration, is silent chest, is imminent of respiratory failure. Remember to ask the cough, the quality of the cough. If it's dry, many times could be a viral condition, or could be, for example, congestive heart failure, or dry cough could be only associated with bronchospasm. Patients that have asthma and they have bronchospastic event, they have paroxysmal cough, they can't stop coughing, but it is dry most of the time. If it's associated with sputum, again, look at the quality of the sputum. Clear to mucus is viral or CHF. If it's light yellow, could be, for example, asthma, because the eosinophils tinge the sputum yellowish, but it's very bright and it's very scant. Compared to dark yellow, greenish, or rusty color, most of the time are bacterial infections. And remember, cough is a reflex. Don't blunt the cough. The cough is necessary to be able to expel the mucus to the outside. What we have to do is give mucolytics to the patient, such as Mucinex, for example. You only blunt the cough when the patients complain that they're unable to sleep due to the cough. So, as I said, ask the patient whether the sputum is dry, white, yellowish, rusty, depending on the color. And the volume. Volume is super important, because when you have patients that have chronic pulmonary conditions, remember that COPD has two components, emphysema and chronic bronchitis. Chronic bronchitis is abundant, copious sputum